Welcome to Topic 8, Disorders of the Digestive System. In this screencast, we'll be discussing Part 1, Disorders of Gastrointestinal Function. We'll start with an overview of normal digestive physiology and discuss some manifestations of gastrointestinal disorders. The function of the digestive system is to access energy in foodstuffs for the body. There are two main categories of organs, those of the alimentary canal or the GI tract. This is that long muscular tube that extends from mouth to anus, and the accessory organs that help aid in digestive processes, including the teeth, the gallbladder, salivary glands, and the liver and pancreas. Let's do a quick overview of digestive functions of different parts of the GI tract. In the mouth, we have mechanical digestion of food, so the teeth chew food, the tongue moves food around, so we're physically making foodstuffs smaller. And then we have the chemical digestion of carbohydrates through salivary amylase. And then the tongue forms food into a bolus and it gets pushed towards the pharynx for swallowing. The pharynx is simply kind of a cavity that connects the mouth to the esophagus, and during swallowing, the trachea gets covered by the epiglottis to prevent aspiration of food or drink. The esophagus is a long muscular tube that extends from the pharynx to the stomach. Food gets moved through the esophagus by peristalsis, those rhythmic waves that keep pushing things further down. We have the cardiac sphincter or lower esophageal sphincter that separates the esophagus from the stomach. The reflux of acidic contents through that sphincter we'll talk about later, and that's GERD. The digestive functions of the stomach. The stomach acts in mixing chyme and liquefying stomach contents. So it mixes it with a bunch of hydrochloric acid. Becomes very acidic. We begin the chemical digestion of proteins, and proteins are digested by pepsin, which gets activated by hydrochloric acid. And then we have regulated release of chyme through the pyloric sphincter into the duodenum. And also we have cells of the stomach that secrete intrinsic factor, if you remember, which is necessary for the absorption of vitamin B12. The pancreas secretes enzymes in response to a hormone, which is cholecystokinin, and it secretes them through pancreatic duct into the duodenum. And the pancreas releases enzymes for all categories of foodstuffs, so lipases for fats, amylases for carbohydrates, and then various peptidases, and other enzymes for the digestion of proteins. Okay, then the pancreas also secretes water bicarbonate mucus, and this is in response to the hormone secretin. So we have two types of cells, the acinar cells, those are the ones that secrete the digestive enzymes, and the ductal cells that secrete water and bicarbonate. And this water and bicarbonate is going to help to neutralize the acidic gastric contents coming from the stomach. So while the stomach is well suited for that acid, the duodenum is not. And so we need to neutralize it, actually make it even slightly basic. Not only for the, well, we need to at least neutralize it for protection of the intestine, but the pancreatic enzymes work best at a slightly alkaline pH. So that's the reason for that. Okay. The liver and gallbladder, their main digestive function is through the production of bile. So the liver produces bile, which emulsifies fats. The gallbladder stores and concentrates this bile. And then that bile gets delivered, it joins the pancreatic duct, and it gets delivered to the duodenum via the common bile duct. The liver also has a lot of metabolic functions, such as gluconeogenesis, glycogenolysis, but we're just going to focus on the digestive functions right now. Okay, digestive functions of the small intestine. The small intestine is where the bulk of digestion and absorption occurs. So in the small intestine, we have the chemical digestion of fats, proteins, and carbohydrates. So bile emulsifies the fats, and then pancreatic enzymes digest carbohydrates, proteins, and fats. And then we also have brush border enzymes that are found within the brush border that complete the digestion of carbohydrates and proteins. So in order to absorb these end products into the intestinal cells, we need to have them broken into their smallest components. So carbohydrates need to be broken down into single sugars or monosaccharides. Proteins need to be broken down into amino acids. Fatty acids are fine as fatty acids because they can go directly through the intestinal epithelial cells. Most water reabsorption also occurs in the small intestine. The large intestine then reabsorbs electrolytes and the remaining water. It's involved in forming and storaging feces and then defecation. We have resident flora that acts on food residues to ferment indigestible stuff, and it provides energy source for epithelial cells. We also have synthesis of vitamin K, which remember is necessary for making some of the coagulation factors by the liver. And I just wanted to mention that broad-spectrum antibiotics can disrupt the normal flora and lead to overgrowth of certain species such as C. diff, which can be difficult to treat. Okay, let's look at the digestion and absorption of the major macronutrients. So carbohydrate digestion starts in the mouth, and then it's followed by digestion in the small intestine. There's no digestion in the stomach. Salivary amylase gets inactivated in that low pH. And then in the carbohydrates, digestion in the small intestine is through the action of pancreatic amylase, and then various brush border enzymes such as lactase. Proteins, digestion starts in the stomach and continues in the small intestine. And then lipids get emulsified by bile prior to the chemical breakdown. And then we have enzymes that break down lipids into monoglycerides and free fatty acids. And these can just diffuse across the intestinal epithelial cell. And then we have the formation of chylomicrons, and then they get extruded by the intestinal epithelial cells, and then they are carried in the lymph to the systemic circulation. Both the carbohydrates and proteins, monosaccharides and amino acids, they go directly into the portal system and travel to the liver, directly to the liver, whereas the lipids travel via the lymph and then enter the systemic circulation. Fat-soluble vitamins get absorbed with fats. Water-soluble vitamins diffuse into the blood. Electrolytes get absorbed by active transport or diffusion. Water is absorbed primarily by osmosis. We get a lot of water that gets added to the digestive tract, but only a small amount of water leaves the body in the feces, only about 50 to 200 mils. So most of the water that enters the digestive tract also gets reabsorbed. Okay, you should take a look at these concept checks, and then we'll go through some questions. The digestion of which substance begins in the mouth? Carbohydrates. How would fat digestion be affected if bile levels were decreased? It would decrease. Because remember, bile breaks down fats into kind of smaller fat particles so that it can be more easily digested by enzymes. A woman has a pancreatic tumor that secretes gastrin. What complication is likely to develop? Now, we haven't talked about gastrin, but gastrin is a hormone that stimulates secretions by parietal cells of the stomach. So they're going to secrete more hydrochloric acid. So if you guess ulcer, that would be correct. Okay, a man cannot produce cholecystokinin. Cholecystokinin is a hormone that causes the release of pancreatic enzymes. So the answer to this, what problems will it cause? Will cause malabsorption problems, because he wouldn't be able to completely break down all categories of foodstuffs, and so he's going to have difficulty absorbing them through the intestinal epithelium. Okay, let's talk about some manifestations of digestive disorders. So you have anorexia, nausea, and vomiting. And these can be a sign of digestive disorders, but they can also be a sign of other conditions elsewhere in the body, such as systemic infection, uremia. It can be emotional responses, motion sickness, pressure on the vomiting center in the brain, overindulgence of food or drugs, and pain. Vomiting in particular can lead to serious complications such as dehydration and acidosis and malnutrition. Okay, vomiting. So the vomiting center is located in the medulla, and this coordinates the activities involved in vomiting. So what causes vomiting? Distension or irritation from the digestive tract, stimuli from parts of the brain, pain or stress, vestibular apparatus of the inner ear, motion sickness, or we can get sudden projectile vomiting if we have an increase in the intracranial pressure within the brain. Stimulation of chemoreceptor trigger zone by things such as drugs, toxins, or chemicals. Let's talk about some characteristics of vomitus. Presence of blood is hematemesis. If it's coffee groundish, like shown in this picture here, brown granular material, that indicates that hydrochloric acid has acted on hemoglobin. So the bleeding is from the stomach, such as a gastric peptic ulcer. If it's bright red blood, or frank hematemesis, this is bleeding above the stomach, and this could be due to like varicose veins in the esophagus, a tear at the esophageal gastric junction. Yellow or green stained vomitus indicates you are vomiting up bile from the duodenum. A deeper brown color can indicate even further down from the lower intestine. Recurrent vomiting of undigested food would suggest a problem with gastric emptying or perhaps an infection. Acute diarrhea is usually caused by infectious agents, and it resolves quickly. We can have non-inflammatory, which is large volume with non-bloody stools, and this is often related to infection. And this can cause problems with normal absorption and secretion in the small intestine, so we can get less absorption or too much secretion, or too much motility, and then this can cause the diarrhea. If it's severe, it can result in dehydration, hypokalemia, and metabolic acidosis. Inflammatory diarrhea is accompanied by fever, and it can be bloody. And it's caused by invasion of intestinal cells by toxins of E. coli or C. diff. And this usually affects the colon, and it results in a small volume diarrhea, where the above usually affects the small intestine, resulting in large volume diarrhea. If it lasts greater than 14 days, you might want, unless they have C. diff, they should be evaluated for ulcerative colitis, which we'll talk about later. Chronic diarrhea. We have symptoms that persist for 3 to 4 weeks. Hyperosmotic diarrhea. So this is where we have non-reabsorbable substances in the intestine that draws excess water into the intestine. So this would occur like with malabsorption syndrome, such as with people that are lactose intolerant. They lack the enzyme lactase to break down lactose into monosaccharides, and we can't absorb disaccharide. So it stays in the gut, keeps water with it, so it acts to cause hyperosmolarity of the diarrhea, I guess, or of the intestine, in the intestine, and that's going to lead to malabsorption syndromes. Excuse. Okay, another type of hyperosmotic diarrhea is if you have decreased transit time. So peristalsis is increased, and then we just don't have enough time to absorb everything, so it acts to keep water with it. So that's essentially what's happening here. These malabsorption syndromes, or decreased transit time, the osmolarity of the stuff in the gut is high because we're not absorbing it. So if we don't absorb it all, then we can't absorb water along with it. Secretory diarrhea is when we have excessive mucosal secretion of fluid and electrolytes, or failure to absorb bile salts, or fat malabsorption. This also occurs in infection. And then we can also get chronic diarrhea in inflammatory bowel diseases, such as Crohn's disease or ulcerative colitis, or we can have chronic parasitic infections. Okay, blood in the stool. Blood can occur in normal stools with diarrhea, constipation, tumors, or inflammatory conditions. If we have frank red blood, this is usually from lesions in the rectum or in the anal canal, so this is bright red blood. Occult blood is when we have just small amounts of blood and we have to use a stool test to be able to detect it. And that can be caused by like small bleeding ulcers. Melena is when we have really dark colored tarry stools, and this is due to significant bleeding in the upper GI tract. Constipation. This is where we have less frequent bowel movements than normal, resulting in small, hard stools. This can be an acute problem or a chronic problem. It can be due to decreased peristalsis, which is going to, so if peristalsis is going slow, then we're going to reabsorb too much fluid. We can alternate periods of constipation with diarrhea. Some complications of chronic constipation, it can lead to hemorrhoids or anal fissures or diverticulitis. And there's a variety of causes. We do see some with aging due to weakness of the smooth muscle, inadequate fiber intake or fluid intake, failure to respond to the defecation reflex, holding it in, immobility, neurological disorders that are going to affect the peristalsis, drugs such as opiates, antacids, iron medications. It also can be due to obstructions caused by tumors or strictures or narrowing of the GI tract. Fluid and electrolyte imbalances. We can get dehydration and hypovolemia as a result of vomiting and diarrhea. Electrolyte loss, we see sodium loss with vomiting and diarrhea, chloride loss with vomiting, potassium loss with diarrhea, as well as bicarbonate loss. That's on the next slide. Next part. So acid-base imbalance. Vomiting leads to loss of hydrochloric acid, resulting in metabolic alkalosis and hypochloremia, or low chlorine. Severe vomiting causes a change to metabolic acidosis due to the loss of bicarbonate eventually from duodenal secretion. So if vomiting is prolonged or severe, we'll vomit up alkaline duodenal secretions, not just the acidic stomach contents. Diarrhea leads to a loss of bicarbonate and metabolic acidosis. Okay, take a look at the concept check and make sure you can answer those questions. Next question. Which symptom accompanies hemorrhage into the stomach? Coffee ground vomitus. So, and that is a classic symptom of blood in the stomach. So it mixes with the chyme to give it a coffee ground color and consistency. All right, we're on to disorders of the GI tract, part 1. Esophageal disorders. So let's talk about dysphagia. Dysphagia means difficulty swallowing, and it results in pain with swallowing, difficulty swallowing, inability to swallow large pieces of solid material, difficulty swallowing liquids, feelings of choking, coughing, or an abnormal sensation of food sticking when swallowing. Now, there's different causes of dysphagia. We can have a neurological deficit due to damage to cranial nerve 5, 7, 9, and 12, any of those, which can be caused by infection or stroke, brain damage. Achalasia is a particular term that refers to failure of the lower esophageal sphincter to relax, and this is due to a lack of neurological innervation. And this kind of leads, so we have a stricture essentially at the bottom here and a dilated esophageal body. This is one cause of dysphagia. Muscular disorders such as muscular dystrophy, Parkinson's, and ALS. Congenital disorders, we could have atresia where the upper and lower esophageal segments are separated. Or we can have a tracheoesophageal fistula. That's an opening, abnormal opening between the trachea and the esophagus. We can have stenosis or narrowing of the esophagus due to fibrosis, chronic inflammation or ulceration. This may occur like with chronic reflux. Scleroderma is a connective tissue disorder that can also affect the esophagus and other places of the body. And tumors. Tumors could also cause narrowing. Okay, hiatal hernia. This is a condition in which part of the stomach protrudes through the opening in the diaphragm called the hiatus. The sliding hernia is a more common type. This is where a portion of the stomach moves up above the diaphragm, but it can also slide back out. So it can move up and back. So like they may be bothering you lying down, and then you stand up and it slides back down. This one can often be asymptomatic. A paraesophageal hernia is where we get part of the stomach that protrudes up above the hiatus and it gets trapped there. And this is more serious and may require surgical treatment, okay, because food can get stuck up there and it can blood flow can get cut off there. So food can lodge in that pouch, causes inflammation. We can get more reflux into the esophagus and chronic esophagitis. There we go. All right, what's next? Gastroesophageal reflux disease, or GERD. This is where we get persistent reflux of gastric contents from the stomach into the esophagus. This leads to erosion of the layers of the esophagus and inflammation. The severity depends on the competence or how well the lower esophageal sphincter closes. Other factors that can contribute if we have delayed gastric emptying, okay, if it's not emptying fully, that's going to make it more fluid in the stomach, and that can back up more easily. An increase in intra-abdominal pressure that can occur with obesity or pregnancy or wearing too tight of jeans. It's often seen in conjunction with a hiatal hernia. Manifestations include heartburn 30 to 60 minutes after eating, and this can be made worse by bending over or lying down in the recumbent position. It's often relieved by the upright position. Okay, gravity helps. It may also cause chest pain, or it feels like chest pain. That's often gets confused with angina. It can lead to wheezing, coughing, and hoarseness if some of the acidic contents irritates the airways. Antacids can provide some transient relief. GERD can also be a trigger for asthma. And there's other complications that can result from persistent reflux in addition to asthma. So GERD can cause intrinsic asthma. We can get inflammation and ulceration that then is followed by fibrosis or scar tissue of the esophageal tissue. This can lead to strictures of the esophagus, which can lead to dysplasia and predisposed to cancer. Barrett esophagus, as shown in the picture here. We have squamous mucosa replaced with columnar epithelium, so that's a form of metaplasia, and that predisposes to the development of adenocarcinoma. In addition, not listed on the slide here, but the scar tissue can cause shortening of the esophagus and actually pull the stomach up through the hiatus, causing a hiatal hernia. Some things are to be avoided if you have GERD, such as caffeine, fatty and spicy foods. Some of the things are because we get more delayed gastric emptying. Alcohol, smoking, and certain drugs. Can't remember the reason for caffeine, but I believe it's because it can cause a little bit increased acid production. There's some use of some medications that can help reduce reflux and inflammation. Antacids help to neutralize acid for rapid relief, such as like Tums. Histamine 2 receptor antagonists, they reduce the gastric acid production. And then we also have proton pump inhibitors to inhibit the gastric proton pump. Acute gastritis is where we have transient inflammation of the gastric mucosa, and this may lead to ulceration and bleeding. It's usually a result of local irritants such as excessive alcohol intake, ingestion of aspirin or other NSAIDs, bacterial toxins, corticosteroids, uremia, or radiation and chemotherapy. Manifestations include anorexia, nausea, vomiting, hematemesis, epigastric pain, cramps, diarrhea, potentially with infection. This is usually self-limiting, and we get complete regeneration of the gastric mucosa after the inciting agent has been removed. Chronic gastritis is where we have chronic inflammation of the gastric mucosa, but in the absence of erosions. Chronic gastritis leads to atrophy of the mucosa of the stomach and a loss of the secretory glands. There are three types, or three causes. One, due to H. pylori infections. This is the most common cause, and this can eventually lead to peptic ulcer disease. Autoimmune disease, which makes up about 10%. This is usually associated with other autoimmune diseases, such as type 1 diabetes mellitus, Addison's disease, thyroiditis. But here this is characterized by autoantibodies to gastric parietal cells, and then this is also going to cause a lack of intrinsic factor because those parietal cells not only secrete acid but also intrinsic factor. So we see decreased acid secretion and pernicious anemia. Chemical, this is a result of chronic gastric injury due to reflux of alkaline duodenal contents, pancreatic secretions, and bile into the stomach. So here we're refluxing through the pyloric sphincter. Manifestations include mild epigastric discomfort, anorexia, intolerance for certain foods, achlorhydria, so that's low or absent chlorine, and megablastic anemia. It's the pernicious anemia. Okay, ulcer disease. With ulcer disease, we have inflammation and ulceration or erosion that can affect one or multiple layers of the GI tract wall. This includes peptic ulcers, which are ulcers found in areas of the GI tract exposed to those acid and pepsin secretions. Of course, this could be the stomach, the esophagus, or the duodenum. Zollinger-Ellison syndrome. This is a specific type of ulcer that's caused by gastrin-secreting tumors. So these are tumors that secrete too much of the hormone gastrin. And gastrin, if you remember, is the hormone that causes secretion of hydrochloric acid from the gastric mucosa. And then we have stress ulcers, and these are ulcers that develop in relation to major physiological stress. This is not the stress of being a student, but rather some major trauma or other type of physiological stress. So for peptic ulcers, the most important risk factors for the development of peptic ulcers are H. pylori infection and the use of aspirin or NSAIDs. There are other factors that can contribute to the development of ulcers, and these include advancing age, corticosteroid drugs, smoking, genetics, and alcohol. But the most important risk factors are H. pylori infection and aspirin or NSAIDs. Peptic ulcers occur most commonly in the proximal duodenum, but they're also found in the stomach as well as in the esophagus if you have reflux of acidic contents into the esophagus. The development usually begins with the breakdown of the mucosal barrier in gastric ulcers. whereas increased acid secretion is the predominant factor in duodenal ulcers. Peptic ulcers can present with epigastric burning pain that occurs between meals, so when the stomach is empty, as well as often occurring between 1 and 2 o'clock in the morning. This pain is usually relieved by ingestion of food or antacids. And this pain can occur in intervals of weeks and months, and then you could go through an asymptomatic period and then have another period of pain. Other manifestations include iron deficiency anemia due to small amounts of blood being lost in the stool, and that's the occult blood. Complications. Hemorrhage. If we have erosion of an ulcer into a blood vessel, it can cause hemorrhage. Acute hemorrhage can result in melena and hematemesis or coffee ground emesis. Insidious bleeding can lead to occult blood in the feces. Obstruction of the GI tract. This can be due to edema, spasm, and then the contraction of scar tissue. This can lead to, this can have a slow onset and lead to epigastric fullness. It can cause GERD, weight loss, and abdominal pain. Perforation is when we have erosion through all the layers of the organ wall, and then this can allow the GI contents to enter the peritoneum, and that can lead to peritonitis. Stress ulcers are associated with severe trauma or systemic problems that cause ischemia and tissue acidosis. This includes things such as large surface area burns or trauma, sepsis, ARDS, liver failure, and some major surgical procedures. There's a rapid onset, so we get multiple ulcers that form within a few hours of the initiating event. Usually, it begins with painless upper GI tract bleeding. Okay, here's the concept check. Go ahead and review those. Next, we move on to Part 2, disorders of the GI tract. Okay, so here we're going to mainly talk about intestinal disorders. Chronic inflammatory bowel disease. These disorders are characterized by periods of remission and exacerbation of diarrhea, fecal urgency, and weight loss. The cause is not known, but there seems to be a combination of factors including intestinal microorganisms, epithelial dysfunction, and activation of inflammatory cells and meat eaters. And these can cause tissue damage, and they seem to do so in genetically predisposed people. There are two types: Crohn's disease, which often begins during adolescence, and ulcerative colitis, which usually begins in your 20s or 30s. So Crohn's disease is characterized by inflammation and fibrotic changes of primarily the submucosal layer, so the layer under the mucosa, of the intestine. And this creates skip lesions. So we get these cobblestone type looking lesions, and then we'll skip a spot and we'll have normal segments of bowel, and then we'll have another cobblestone appearance, and so forth. Over time, this progressive inflammation and fibrosis can lead to obstruction, and also we have damaged walls of the intestine. That's going to lead to poor absorption of food. This inflammation also stimulates intestinal motility, which is going to lead to diarrhea. So manifestations. We have periods of exacerbation and remission, intermittent diarrhea, and this causes kind of a colicky pain, so it's like on and off periods of intense cramping in the lower right quadrant. We get weight loss, electrolyte disorders, low-grade fever, and malaise. So signs of inflammation there. Other complications, we can get ulceration of the perianal skin, nutritional deficiencies, delayed growth or malnutrition in children. And we can end up getting adhesions between the loops of intestines, or maybe even fistulas, those abnormal openings between segments of intestine, and this can result in mechanical intestinal obstructions. Treatments aimed at a nutritious diet that's low in bulk and residue, immunosuppressant drugs to suppress the inflammatory response, and potentially surgery to remove diseased bowel. Ulcerative colitis, this is where we have inflammation of the innermost layer of the GI tract, the mucosa, as well as then the second layer of the submucosa. And this disorder starts in the rectum and it progresses through the colon. So we get ulceration and abscess formation and tissue necrosis. And this is going to also interfere with the absorption of fluid, electrolyte, and foodstuff in the colon. So this is going to present with attacks of bloody and mucus-filled diarrhea. It's bloody because it's involving mainly that mucosal layer. Filled diarrhea that lasts for days, weeks, or months, and then we can have asymptomatic periods of up to months and decades. Manifestations. Manifestations are going to depend on the severity of the disorder. Mild, which is the most common form, you have less than 4 stools a day with some bleeding and urgency, and lower left quadrant cramping. Moderate, we have more severe diarrhea, bleeding, abdominal pain with some fever and anemia. Severe is characterized by 6 or more stools a day with severe anemia, hypovolemia, and impaired nutrition. And then we can also have a severe acute episode or fulminant ulcerative colitis, also called toxic megacolon. And here we have up to 12 stools a day with fever, severe hypovolemia, and hemorrhaging that can require transfusion. Let's compare the lesions in Crohn's versus ulcerative colitis. So remember, Crohn's disease is characterized by skip lesions that occur in the submucosa, primarily in the ileum and then secondarily in the colon. Ulcerative colitis is characterized by continuous lesions that start in the rectum and ascend the colon. Diverticulum is when we have a herniation of the mucosa layer through the muscle layer of the colon, usually the sigmoid colon. This is really prevalent in developed countries, but not very prevalent in underdeveloped countries, which may suggest a role of low fiber diet and a lack of physical activity in developed countries. Diverticulosis is the asymptomatic diverticular disease. So we have the diverticula, but they're not inflamed. Diverticulitis is when we get inflammation and then perforation of the diverticula. Here's showing some diverticulum. And this can result in pain and tenderness over the lower left quadrant, where the sigmoid colon is found, nausea and vomiting, fever, and elevated white blood cell count. Treatment is through the use of antibacterial drugs and dietary modifications to help keep things moving. Appendicitis is when we have inflammation of the wall of the appendix. This can become swollen, and then it can become gangrenous, and untreated, eventually it could perforate. It's most common in 20 to 30-year-olds, but can occur in children and later adulthood. The cause is thought to be an obstruction, like due to a fecal stone right there, or twisting that can block off that and allow it to become inflamed and swollen. So how does it develop? We start with obstruction of the appendiceal lumen. Fluid builds up inside the appendix, and this allows microorganisms to proliferate. This causes the appendix wall to become inflamed and swollen. This moves to ischemia and necrosis of the wall, which is going to cause it to be increase in permeability. It's going to cause an inflammatory response with increased permeability. Bacteria and toxins can then escape into the surroundings, leading to bacterial peritonitis. An abscess can develop if that inflamed area gets walled off, and that may lead to a temporary decrease in pain and inflammation. But then we end up getting necrosis and gangrene of the wall, and eventually this can cause the appendix to rupture or perforate, and then it releases its contents into the peritoneal cavity, and that can cause peritonitis. Let's talk about the progression of appendicitis. The first step, we see general periumbilical pain. And so this is pain right around the umbilicus or belly button. And this is related to the inflammation. Nausea and vomiting are also common during this stage. You just don't feel well. Later on, the pain becomes severe and localized in the lower right quadrant where the appendix would be found. We can also often see a classic sign, although my husband did not have this, is the lower right quadrant rebound tenderness, and that's where you press in the lower right quadrant, and then when you let go, you get more pain with when you let go, when it rebounds. And this indicates involvement of the parietal peritoneum, which is over the appendix. After rupture, the pain can decrease temporarily. So if you think you have a really swollen appendix, it's very uncomfortable. But if it ruptures, that relieves some of that pressure and the pain temporarily decreases. But all that bacteria gets strewn into the peritoneal cavity, and this results in peritonitis. And with peritonitis, then we get severe pain that reoccurs. Now it's more generalized abdominal pain and guarding. So we develop kind of this board-like abdomen with reflex contraction. This causes, so the abdominal muscle walls are spasmed and tight. We get low-grade fever and leukocytosis, tachycardia, hypotension, and then we can have reduced blood pressure due to the bacterial endotoxins. Treatment is aimed at surgical removal of the appendix and antimicrobial drugs. Let's talk about acute intestinal obstruction. This is where we have a lack of movement of the intestinal contents through the intestine. This is more common and more severe in the small intestine than in the large intestine. So there's usually a small intestine, and this can be life-threatening if it's not corrected earlier. Now, this obstruction may be physical or mechanical, or it can be non-mechanical. Let's start talking about mechanical causes first. The most common mechanical cause is an external hernia. This shows here an inguinal hernia where the intestine herniates through an opening in the peritoneum. We can also, other common causes are adhesions post-operative. Less common, we can have strictures or narrowing, tumors or foreign bodies, intussusception or telescoping, shown here, volvulus, which is twisting of the intestine. Well, let's look at the progression of mechanical obstruction. So we start with, we have a mechanical obstruction, and gases and fluids are going to accumulate proximal to that blockage. And this is going to cause increasingly stronger peristaltic contractions to try and push that stuff through past the obstruction. This is going to cause pressure to increase in the lumen, which will cause more secretions to enter the intestine. The intestinal wall becomes edematous. This distension is going to lead to vomiting, and then we're gonna lose more fluid and electrolytes, and this can cause hypovolemia. We then have ischemia and necrosis of the intestinal wall because we have compromised blood flow, and this is going to cause decreased innervation, which can lead to paralytic ileus, which is a non-mechanical obstruction. Next, we get rapid production of intestinal bacteria, and this they can leak out because this becomes more, what's the word I'm looking for? Permeable. The bowel becomes more permeable, and they can leak out into the peritoneal cavity, causing peritonitis, or into the blood, causing bacteremia and septicemia. We also may get complete perforation, where this perforates and bacteria comes out into the abdominal cavity here, resulting in general peritonitis and septic shock. Non-mechanical intestinal obstruction, also called paralytic ileus. This is where we have neurogenic or muscular impairment of peristalsis. It most commonly occurs post-abdominal surgery. Other causes include spinal shock following spinal cord injuries, inflammation related to ischemia, pancreatitis, peritonitis, hypokalemia, mesenteric thrombosis, and toxemia. So this is one of the reasons why it's always, they don't want to discharge a patient until they've made sure that they've had a bowel movement. Signs and symptoms of intestinal obstruction. With mechanical obstruction, we have severe colicky abdominal pain, so severe waves of pain, and we would hear intermittent bowel sounds with each wave of peristalsis. In contrast, paralytic ileus, the pain is steady, so it's not colicky with each wave of peristalsis. Rather, it's just steady. The bowel sounds are decreased or absent, okay, because the problem is a lack of peristalsis. Both cases, we get vomiting and abdominal distension. This occurs very quickly with obstruction of the small intestine. Vomiting is recurrent, usually or eventually bile stained. And this, once again, is a severe medical emergency. With malabsorption syndromes, we have impaired digestion and or absorption of nutrients resulting in steatorrhea, which is fatty, foul-smelling, yellow-gray stools, muscle wasting, and weight loss despite a normal caloric intake. Other symptoms include bloating, abdominal cramps, and flatulence. This can be caused by pancreatic insufficiency. Now remember, the pancreas secretes enzymes to break down all categories of foodstuff. So lipase is for fat, amylase for carbohydrate, and various proteases for protein digestion. So without these enzymes, we cannot absorb, we cannot digest these macronutrients into their simplest form, so then we cannot reabsorb them across the intestinal epithelial wall. So this is caused by chronic pancreatitis or cancer, resection of the pancreas, or cystic fibrosis. Bile salt deficiency. This is where we don't have enough bile salts for the emulsification of fats. This is going to be caused by liver disease or obstruction of the bile duct, diseases of the ileum, because the ileum recycles bile salts. So this is going to result in poor digestion of fats. And lactase deficiency. This is when we have an insufficiency of the brush border enzyme lactase. And if you remember, lactase is the enzyme that breaks down lactose into monosaccharides. So without lactase, we can't digest lactose, and then we can't absorb lactose across the intestinal epithelium. So if we can't absorb it, then we lose some osmotic gradient for water to be reabsorbed, so it results in some osmotic diarrhea. And then last we have celiac disease. Celiac disease is an immune-mediated genetic disorder caused by ingestion of gluten-containing grains, which are wheat, barley, and rye. This affects about 1% of the population. And this is due to a T-cell mediated response that results in an inflammatory reaction and the loss of absorptive intestinal villi. So here's what our villi should look like. Here's with celiac disease. And obviously this is going to result in poor absorption, so malabsorption, and malnutrition. This usually manifests in early childhood, but it's also being increasingly recognized in adults. The manifestation is going to depend on the age group, but often includes the steatorrhea, abdominal distension or discomfort, muscle wasting, and in young children, failure to gain weight or thrive. The elderly may present with milder abdominal symptoms, but oftentimes they can have anemia or osteoporosis or osteomalacia. Diagnosis is made by a series of blood tests, and if they're positive, this is followed up by an intestinal biopsy. The treatment is a gluten-free diet, and on that gluten-free diet, the intestinal mucosa can completely return to normal after a few weeks without gluten. So the treatment: gluten-free, no wheat, no barley, no rye. Oat products are considered non-toxic, but sometimes they're processed in the same plant with wheat, so they can become contaminated. So many celiacs may also avoid oats. All right, take a look at this concept checks, and we'll see you back for part 2.